And as a transition, I actually happen to have a silicone breast implant on my desk. Why? You can ask me questions about that later, but thank you for the introduction. So we'll talk today about some clinical challenges and issues around post-burn fibrotic scarring. As mentioned, I'm a clinician scientist, and I have no disclosures related to this presentation. So I'm going to talk a little bit about what burn injuries look like in North America in comparison to the rest of the world. Consider what we think are some possible mechanisms in burn scar development and what those look like clinically. I'm going to review some of the treatment options for burn scar fibrosis and increased volume. Burn scars have many characteristics, but for the purposes of this talk, we're going to talk about the fibrosis and volume issues. And then I'm going to give you along the way some snapshots about scar-specific research. So if we consider in North America, probably there are about 500,000 people a year that require physician assistance in managing their burn injuries, and about 40,000 people a year that get admitted to hospital. So this is quite a common injury, and I just use in comparison other things people hear about frequently. Consider probably North America about 11,000 people a year with spinal cord injuries, and ALS is another debilitating disease. There are only about 5,000 cases a year in North America. So who gets burned? This is data from the American Burn Association. And although it's the American Burn Association, there are centers in Canada and Australia that also submit to this. But what we can see is that in North America, the vast majority of burn injuries tend to be men, sometime between the ages of about 20 and 35 is about the peak of who gets burned here in Canada and the United States. That's not the case worldwide. So this is a similar snapshot in time from the World Health Organization, where we can see that actually worldwide burn injury tends to be very strongly a pediatric disease. Small peak, again, around 20 to 40 years old, but nowhere near as much. This tells us that actually burn prevention in Canada, the United States, also in Europe, actually is quite effective. And so we have a very different kind of demographic here than in most of the world. What happens to people that they end up coming to see me or another burn provider? Vast majority of people here mostly get scald injuries and almost the same number of flame injuries. It's a pretty even mixture between the two. And then there's a variety of other etiologies that can explain how people get injured. Again, if we go worldwide though, instead of scald injuries, we get vast majority of worldwide injuries are flame. And so this is sometimes explained by differences in home heating, but also a vast majority of these injuries are thought to be associated with cooking practices, and particularly cooking practices that involve open flame at ground level. So that can help explain both why children tend to get more injuries in other parts of the world and why there's more flame. What happens though? Well, in North America, we get the vast majority of our burn patients go home. So this is a total mortality. We look at about 3% in North America. And at our center here in Calgary, we consider that every burn injury is survivable. So barring another disease process happening for a patient, when someone comes to our center here, we're thinking that in the long term, eventually they are going to return to the community. Again, though, worldwide, that's not the case. So here it's about 9,000 cases, and we see that not quite 2,000 of them don't survive. So this is just giving you a framework to say that advanced modern medical and surgical technique availability vastly changes survival. And that is played out across the world. So we can see that in what the World Health Organization considers like the high to middle income countries, mortality is significantly different. And the incidence changes very differently too. So In what the World Health Organization considers the Western Pacific region, the incidence of burn injury is about 20 times higher than it is in the Americas region. So worldwide, burn injury is very common. We've made huge advancements in treatment over the last several decades, but for places where the access to that care is limited, things really haven't changed in the last century. But what happens here? So this is a recent article. Something comes to the news where there's a house fire and multiple people injured, one that may have died at the scene. So when they present to us, we're faced with significant injury to the skin. And in normal wound healing, we've seen images like this before, or descriptions of orderly progression in wound healing from the initial clot formation and moving through an inflammatory stage of wound healing to eventually a long-term remodeling in the skin and the original injury site. So when I think of wound healing, we kind of have a few different fates. So we consider normal wound healing that results in similar function and appearance and sensory characteristics. There's two different ways things can go. We can have the hyperproliferative or non-healing wound that never really forms a stable epithelium. And this is the chronic non-healing wound. But what we see much more commonly after burns or other acute wounds in my practice is the dermatoproliferative wound healing. So they have increased volume, different pigmentation, contour as far as the appearance goes. They tend to be itchy and somewhat painful, and it's related to this prolonged inflammatory state of wound healing and the patient's own genetic potential. We know that there is a significant inflammatory response to burn injury. So it's almost predictable in patients that have total body surface area burns that are at least 20%, certainly by 30%, and by 40% total body surface area full thickness burn, there's a huge increase in the patient's metabolic needs, much more so than we see in sepsis or in general trauma. So what do all of these things mean as far as the skin and the scar and the wound outcome? Well, what we think is that some of this very early inflammatory signaling takes the fate of the fibroblast and determines that it's going to become more of a pro-fibrotic state. And we'll come back to this a little bit later, but I want to put the framework that probably I'll steal one of my trainees' phrases and say that we don't exactly know when a scar is born, but it is probably in these very early stages of neutrophil fibroblast communication that determines what ends up happening in the end. And so what does this look like meaningfully for me in the clinic? And so we have those characteristics that I saw. And so this is a patient with a full thickness face and neck burn that has these typical characteristics where they're thick, they're raised, they're very stiff and contractile. So in this case, the contraction is such that this everted the patient's lower lip has caused a significant dysphagia or inability to eat and speak properly. So this person can't retain liquids in normal viscosity or food with this sort of deformity. We know it's quite different when we take a look at scar and when we try to skin graft acute wounds. This is some imaging from a paper that one of our postdoctoral fellows had completed a few years ago that really shows mostly the right-hand side is the disorganized nature of collagen in scar and in skin graft. So what does it look like? We know that it's different, but a challenge clinically is how do we describe this and how do we measure it? So on the left of this is something called the Vancouver Scar Scale, which is a clinical scale that is used, unfortunately, quite frequently in how to describe the severity of scar. If you take a look at this patient on the back, on the right-hand side, who has this extensive back scarring, you can see there are areas that you might consider to be red, pink, or purple. And so when a clinical scale like this already could vary by 3 points You know, and it's been demonstrated again and again that the inter-rater reliability of these kind of clinical tools is really quite poor. So we tried to come up with some ways and test some technologies to see how could we better define what SCAR is and how can we measure change in SCAR. So one of the things that had been out for a while was high frequency ultrasound. So we know that ultrasound wave and reflection can give us some imaging of deep tissues. So when you have a abdominal ultrasound is a lower frequency than say what we used in this investigation, which was high frequency ultrasound. It doesn't penetrate very deeply, but does provide quite an accurate measurement of epidermal thickness. But unfortunately, we found with this technology did not really penetrate as deeply as we would have needed to get a whole picture of the scar. So we've kind of moved a bit away from high frequency ultrasound to other imaging techniques. And this is one called stereophotogrammetry. And we've done some preclinical studies and now moved into clinical studies to make digital mesh over surface areas that then allows us to measure positive volume and texture changes in skin and scar. So this doesn't give us a thickness of the dermis necessarily, but it might be more clinically relevant. So for me, when a patient comes to me with a scar, if it's flat, we don't do as many interventions. If it's raised around compared to the normal surrounding skin, then we intervene. So this is a technique that we're using to try to refine better what scar outcome looks like. So what do we do about it? Well, historically, you may have seen people that have had pressure garments applied or heard about this. Some people also make custom face masks or devices to try to flatten a scar. But really, this hasn't panned out, and this has been known around the burn community for the most part, that really putting pressure on a scar doesn't change it in the long term. So in my practice, we've gotten away from this other than to use a pressure garment, perhaps as an environmental or social barrier for people that have discomfort with dependent leg burns. But what we've seen over time is that really just putting pressure or putting pressure and silicone together doesn't change the long-term outcome. The other thing that is commonly done is to inject steroid into skin and scar that has some fibrosis and increased volume. And there's probably some benefit to this. Why it is, we can't entirely be sure. Some thought is that, yes, there's a prolonged inflammatory state. And as a result, the remodeling stage in scar's life might be altered. There might be some benefit to actually mechanically perforating the skin and scar. But this shows some moderate benefit. Unfortunately, it's not really very satisfying. So although, yes, it might be perhaps a millimeter or so thinner, sometimes we have scars that are at least a centimeter thick, in which case that amount of change is not necessarily satisfying to the patient nor to the clinician. Something else non-operatively that's quite common, and this is just a scan of different wavelengths of laser light that's used to try and modulate scar outcome, is that we frequently see, and we do in our practice here too, an attempt to try to change a scar's characteristics by perforating it with light. And mostly what we use is fractional carbon dioxide laser. So with this, we take a beam of energy and make a variety of perforations within a scar. Now, the thing with this is I stole this from some dermatology clinic. And this is a pretty, well, let's face it, this is kind of a dumb slide, but it just says skin with problem. And then we shoot holes in it with a laser and then it gets better. But I also think this kind of sums up a lot of what we know about fractional carbon dioxide laser therapy and scar remodeling. In my clinical practice, I would say perhaps it does actually improve scar volume to a degree and the elasticity somewhat. We're not entirely sure how, and not all patients necessarily respond well to this. So we're doing a study here. We're taking patients that have scars and doing a within subject control. So we treat half of the scar with laser and half of the scar without. And we use some of our imaging techniques as well as in vivo mechanical testing to try and get an idea about how much difference do we actually make with laser treatment. And we also biopsy these to try and come up with some idea that we can interrogate what might be the possible mechanisms behind benefit in scar resurfacing techniques. So we look to the literature though, and we see papers like this that say that fractional carbon dioxide laser therapy is safe, cost-effective, and efficacious. But when you really get into it though, this is really all based on studies that use things like the Vancouver Scar Scale or those clinical tools that I described earlier. They're not very reliable. So the literature is really lacking in this space. And fractional carbon dioxide and other laser therapies are a bit of an interest for me because it's quite expensive to purchase and provide this kind of treatment. And if we're not really convinced about the effectiveness nor necessarily the mechanism, we need to be a bit more critical than this in proceeding with future laser studies. People ask me all the time about topical therapies, and I just picked this piece of publicly available art of a topical cream because really we have no effective topical therapies to try to change burn scar fibrosis or volume. Burn scar does tend quite dry because the sebaceous glands and other dermal adnexa are not present in significant burn scar. And so any emollient cream tends to be beneficial to the patient as far as how they feel, but it doesn't make a long-term difference in what happens with their skin. So what we think is that it's this early phase where we need to be thinking about how do we actually be influential in whether a burn scar is developed or a patient develops more normal skin after injury. And so it might be that we can find targets here to try to be influential in what that fibroblast fate is. Our other consideration, and something we've been working on here in our laboratory, is how can we change the population of fibroblasts? And this was a paper that we published not too long ago, where we were doing a human to mouse xenograft model and infusing the split thickness skin graft with dermal progenitor cells to try and alter the characteristics of the graft in the long term, which showed quite a bit of promise, not only in the fibrotic outcomes, but also in some of the other secondary clinical features like scratching and itching that is typical in burn scar. So to wrap this one up, just giving you a brief taste of what I do every day is that burn injuries are common, they're a worldwide problem. Most people survive, but all of them that do survive tend to have some long-term scarring problem. There's probably, we can describe this best as a fibroblast dysfunction that creates disordered extracellular matrix. It's going to be helpful for us to use quantifiable measures in the clinical state to help define our outcomes. There's some minor benefit from things like injections and laser therapies, but we don't really understand how they work. And it's my feeling that future interventions likely to come from either altering the fibroblast fate or changing the population early after injury. So that's my brief look into my world. And I'm very happy to be here and look forward to answering questions at the end.